Okay, that's fine. All right, good morning, everyone. I'm pleased to see a good turnout, and I know we'll have lots of people online as well. I'm in sort of an odd position here this morning because I've read a lot of our speakers' work, but I seem to be one of, there are a large number of people who've actually met and worked with and collaborated with today's speaker and are very excited about him being here, but this is my first time meeting him today. Dr. Benjamin Smith is from McGill. He has actually several appointments, primarily for their Department of Medicine, but he's involved in translational research. He's a scientist with expertise in the area of airway dysanapsis. Now, the fellows may or may not be aware that dysanapsis made it onto the Royal College exam last year, which was a big surprise to people. Even though it's a concept that's been around for 50 years. And I think part of the reason that it's just hitting the mainstream over the past 20 years is that modern techniques allow people to characterize things better. And one of the people who's on the forefront of this is Dr. Smith. So he's going to speak to us. It's a double feature today. First talk, clinical rounds, airway dysanapsis. The second talk is going to be research rounds on immune dysanapsis, which is a very intriguing title. So it's going to be a fantastic talk. Everyone, please enjoy.
All right, so good morning, everyone, and thanks for being here, virtually or in person. Thanks for your attention. Thanks to Manali for inviting me. So this first talk is, I tried to direct it towards a clinical audience, so there's a fair amount of research data, but I'll always try to look at it through a clinical lens. So we'll dive right in. These are my funding sources. I don't think I don't perceive sort of a bias from them. So the overview of the talk, I'll highlight some of the history. As was mentioned, the term dysanapsis has been around for 5 decades. And then I'll discuss what I think are some of the implications to lung health. A lot of this remains sort of in the research milieu, but I think it actually has a lot of applications in how we care for patients, how we understand the heterogeneity of the patients we see. We're not yet at intervening upon it in terms of preventing or treating it. But I think it's sort of changed the way I understand my patients' trajectories in many ways. So hopefully you'll gain some value from that. And then I'll highlight knowledge gaps. So it starts back in 1974. Doctors Green, Mead, and Turner. They did something pretty simple, I think, elegant. They were physiologists at heart, and they were interested in the variability in maximum expiratory flow volume curves. So these are things that you encounter, I'm sure, I hope, every day in clinical practice. So for vital capacity maneuver, looking at that curve. And what they noticed was that there was a lot of variation in the shape. So they wanted to explore that further. So the first thing they did was they collected 56 apparently healthy adults, young adults, so 18 to 54 years old. And they assessed their maximum expiratory flow volume curves. So on the y-axis here, this is how they depicted flow in liters per second, and on the x-axis, the volume. So I think you're familiar with this triangular shape. And they focused on the latter portion of the curve because it was understood, and I think it's still understood, that this portion of the flow curve is less effort dependent. And one thing to note before we look at their main results was that it seems that back in the day, in the 1970s, they depicted things sort of in a reverse x-axis. So just so you are oriented to the way their data look, it's going to look something more like this. And this was really their main finding. So what they plotted was the flow versus volume as a percentage of the vital capacity. And the dotted lines here are the range of values, the 95% range of values observed. So it's not an estimate of how precise the mean was in a larger population. It was the actual distribution of observed values. And so they were struck by how wide this curve was. It was evident in 18 to 25-year-olds and all the way up to 46 to 55-year-olds. And that was really the thrust of their paper. What did they do next? They tried to identify systematically the source of this variation. As I mentioned, they expressed it per vital capacities. The reason they did this was they thought maybe the flows vary based on the size of the lung. But as you saw, there was still a lot of variation. They expressed it per total lung capacities measured by plethysmography, but the variation persisted. They, of course, these were like preeminent physiologists of the day, so they made sure that all the technical aspects of the calibration, the equipment, and so on was not a source of variation. They made sure that the pre-maneuver breathing was standardized. So did they take a big TLC before or not? They repeated several flow measurements. Typically, we stop at 8. They went up to 20. They assessed whether it was variation in the level of bronchoconstriction. They restricted to never smokers because, in fact, in the 56 apparently healthy adults, there were some smokers, but not many. And they assessed the lung recoil using gastroesophageal balloons. And so after trying or evaluating all of these potential sources of variation, they were still left with a ton of variation. And so this is what they concluded. Our results suggest that there is substantial between individual differences in airway size independent of lung size. This was really a hypothesis resulting from their observations. They didn't directly measure the dimensions of the airway tree back in the 70s. These differences may reflect disproportionate growth, and it may even predispose to certain pathologies, particularly when associated with environmental hazards such as cigarette smoke or air pollution. We suggest the word dysynaptic from the Greek, where dys refers to unequal and anaptixy refers to growth, so unequal growth, to indicate this concept. So the takeaway for me at least, from this paper was that dysynapsis or dysynaptic growth was a hypothesis to explain some observed physiology. Now, over the past 5 decades, there was sort of some interest in this, I think more in the sort of physiology realm for several decades, but then in the 21st century, things seem to take off. Perhaps, well, we can speculate as to why. Just perusing these abstracts and articles, there's a fair amount of sort of thought pieces on the subject, but there has been a lot of interesting original research. People have been studying various organisms from mice up to humans, horses and as well. They've studied dysynapsis across the life course and also in various disease contexts, both healthy, but also asthma. It's been heavily studied, obesity, cystic fibrosis, etc. People have used various tools to assess dysynapsis. And so this is why I spent a fair amount of time on the original paper and their definition, because, the concept is really a structural one. It's not always easy to assess the internal structure of a human or an animal. So people come up with alternate methods to assess, but it's always good to be mindful of what's being measured in reference to what the actual definition is. And lastly, there's even been some experimental studies, which I think is quite interesting, where people have varied levels of oxygen, carbon dioxide exposures to see how the lung grows and whether there is dysynapsis evident and whether it can actually be perturbed in adulthood.
Sorry, can I ask a simple question? Did unequal refer to unequal between individuals or unequal within an individual? Because presumably the FEV1 measurement didn't have the same width of variation as this number.
So they're referring to within individual, I'll use the term mismatch between airway and lung size. And I think a nuance that some people don't always appreciate is that that's a pretty broad definition. That can mean the mismatch can be either with respect to the airways or to the lung. It can be too small, which is what most people think of, airways too small. But it could also be too big, so lungs too big. And so that's the context of the definition. I'll get into maybe the unpacking FEV1 versus the ratio a bit down the way. Tends to be mainly the FEV1 that's driving it. So we had that hypothesis 50 years ago. What's happened since? Well, one avenue that's been, I think, enlightening is the capacity to image the internal structure of the lung. And so in this study, we took a large number of people from the general population, adults who had never smoked, never had a diagnosis of lung disease, never lived with a smoker, never had an occupational exposure to vapor gas, dust, or fumes. So we thought these were sort of a look into what native lung structure is in the general population. And we saw that there was indeed quite a bit of variation in the airway tree caliber relative to lung size. This person having little twigs for airways and this person having much larger airways. And so we came up with some way to quantify the airway caliber and the lung volume to come up with a ratio, the airway to lung ratio, just measuring, it's not that complicated, just measuring the diameters of the airway lumens from the trachea to the subsegments and dividing by the size of the lung. This measure has some nice sort of research properties and clinical properties in that it's highly reproducible. Even if you take people and scan them twice a few days apart, you get a very consistent, little variation between the measurement within individuals and most of the variation coming from between individuals. If you follow people for a really long time, well, for 6.2 years, this trait doesn't seem to vary very much. This is in adulthood, of course. So it seems to be a stable property, for better or for worse. And when these images are from people who are on average in their late 50s, early 60s. But when we looked to younger samples, so early adulthood in people in their 20s, and we look at the variation in this ratio across the sample of individuals, it's evident, you know, from your 20s onward. For those interested in obstructive pathophysiology, where we think a lot of the action is in the peripheral airways, I'm not totally convinced of that, but well, I think it is there, but I think it's also central. But nevertheless, in collaboration with Jim Hogg and company, we were able to show that this central trait of the airway tree seems to extend to the terminal bronchioles. So people with smaller central airway trees had narrower terminal bronchioles. People with bigger central airway trees had the opposite. We've tried to probe some of the genetics, which I won't belabor, doing a genome-wide association study. As you might expect, there are several genetic variants associated with this trait, many of which are known to be involved in lung development, which is reassuring. Also are expressed in lung tissue, as one might expect. And so when we compute this dysanapsis genetic risk, we see quite strong associations with your FEV1 FVC, not just in older adulthood, but also as young as 5 years old. These samples are from the UK Biobank. This is from the child study, which is a Canadian multi-site birth cohort. So suggesting that this trait is established quite early, for better or for worse. Now, thinking clinically always, what are the implications for lung health? So in CanCold, which is an adult cohort, which some of you might be familiar with, about 1,500 Canadians sampled from 9 sites across Canada, followed over time, imaged, spirometry, etc. What we found was that, as you might expect, people at this end of the spectrum have a much higher risk of developing incident COPD. COPD here defined by post-bronchodilator spirometry and respiratory symptoms. So I think, clinically relevant COPD. And this was replicated in some multi-ethnic US cohorts as well. Another thing that some people asked, reviewers in particular, was, well, okay, this is a risk factor for COPD. How big of a risk factor is it? So one approach to doing this, there's no perfect approach, but we can try to quantify the amount of variance in FEV1 over FVC explained in the population. If we just include age, sex, height, and race ethnicity, that explains 3.4% of the variance. To my surprise, adding cigarette smoking status, pipe and cigar smoking status, pack years, pipe years, cigar years, secondhand smoke exposures, occupational exposures, PM 2.5, residential, if we throw in the kitchen sink of risk factors, traditional risk factors, we get an additional 8.3% of variation explained. And then if we add to that, this, what we think of as an estimate of airway to lung mismatch, it explains by far the largest proportion of variance, above and beyond those factors initially considered. So this seems to be a pretty big risk factor. And beyond COPD, incident disease, it's also associated with all-cause mortality. So this is a Kaplan-Meier survival curves for the different quartiles of this airway to lung ratio. So small, meaning small airways, big, meaning bigger airways. And there's a substantially increased mortality. The hazard ratio 2.38 comparing the lowest quartile to the highest quartile. So this is not a benign condition, I would say. We see very similar results among never smokers and ever smokers. So I don't think that what we're measuring is the effects of smoke on the lung structure. These estimates are also adjusted for, many of the risk factors known to affect lung structure and lung health, like smoking, air pollutants, asthma diagnosis, etc. And what's really curious to me was when we looked into the causes of death, for sure COPD was front and center, a very large hazard ratio. But, I was thinking Dysanapsis, okay, I get it, smaller pipes, that's an airflow problem, that's classic physiology, it should really just be COPD. But what's very curious to me is that they're actually dying also from cardiovascular disease, lung cancer. And so we'll explore this a bit more in the next talk, but this was quite striking to me. So what could the potential mechanisms be? Well, when we collaborate with biomedical engineers and give them these scans, they can simulate how things deposit in the lung. And they say, this was truly unbiased, I didn't feed them to tweak their assumptions to make it do what I was hoping. But they came back and said, when we simulate particle deposition in this geometry, we get a higher amount of particle deposition in the lung, both the airways and the acini, in contrast to people with these bigger airways. Now, this is purely hypothesis generating. While the geometries were sort of real, the actual deposition, all of that was just fancy computer models. And so the range of particle sizes that exhibited higher deposition were between 0.05 and 1. So interesting, but what do you do with that information? So having access to sort of nicely phenotyped cohorts, we thought, well, we know that smoking is associated with higher cotinine levels in the blood and urine. Cotinine is a metabolite of nicotine. And so we thought, well, for a given amount of smoking, do people with these dysynaptic lungs have higher levels of cotinine in their, well, in this case, in their urine? And so in a cohort called the MESA lung, there was 257 participants who were current smokers. And we saw that the amount of cotinine was significantly higher in those with this smaller airway to lung ratio, controlling for the number of cigarettes smoked per day, other sources of nicotine like chewing tobacco. So this, it's all observational, but I think it complements some of that fluid the simulated stuff. We can also look at other risk factors for lung health and see if dysynapsis, as assessed this way, modifies the susceptibility. So this was in can cold. It was cross-sectional, but we know that 10 pack years of smoking is bad for your lung function. We know that PM 2.5 is bad for your lung function, but the magnitude of that harm seems to depend on your lung structure, your airway to lung ratio. People who had those smaller airway to lung ratios appear to be more susceptible to the harmful effects. So this is in milliliters. So is it clinically relevant? That's another discussion, but suggests that this is not a sort of something that it's not an inert thing that you just are endowed with and you live your life. It seems like you might be more susceptible. Some later work actually sort of that was cross-sectional. So we wanted to, well, is it prospectively, do people who start out with these smaller airway to lung ratios, do they experience more rapid FEV1 decline? This was looking at indoor air pollution in a multi-site US study. And here you have people with the smaller airway to lung ratio. Here you have people with the bigger airway to lung ratio. And the effects of high indoor air pollution on FEV1 decline were really evident in this susceptible lung, shall we call it. Sometimes hard to depict interactions, but here we are. So we were thinking more about this. How can we approach this experimentally? Other particles that we inhale, of course, are pharmacotherapies, well known to the Firestone. And so we thought, well, let's take a bunch of people and have them inhale a short-acting beta agonist. And let's see if the efficacy or the effect of that drug on bronchodilation differs by this airway to lung ratio. And so here we're looking at can cold. We wanted to look at, well, we looked in all participants, of course. So if you give everyone in can cold, sort of 14 or 1,500 some odd people, a standard dose of short-acting bronchodilator. So this is just pre-post spirometry. You get an average change in their FEV1 of 104 milliliters. But that, in the smaller quartile group, there was a larger increment, and in the higher quartile group, there was a smaller increment in FEV1. And we thought, well, maybe there's some undiagnosed asthma, there's some COPD, there's what. And so what we did was try to look at various subsets who we thought there's probably not too much asthma or COPD going on. And as you can see here, this is the difference in that FEV1 change between the smaller airway to lung ratio and the higher airway to lung ratio. And what struck me was that it's actually pretty consistent across the board. So I don't think that this is some undiagnosed asthma. I think this is probably or potentially altered particle deposition or perhaps something else that I'm not aware of. So what are the remaining knowledge gaps that we're left with? Well, can we act on this or can we prevent it? So by definition, this forms early in life because it's about growth. Everything I've shown you so far has been studied in adults. If it's all genetic, that would be pretty or disappointing, I suppose, or harder to act upon. But in fact, the Dysanapsis genetic risk score that we developed accounts for a very small proportion of the trait variance, as do most polygenic scores. So I think that is potentially an opportunity to identify modifiable early life growth conditions. That's something we're doing actively now. And there certainly are some things, markers of early life socioeconomic status, for example, are associated with the more dysynaptic small airway phenotype. Can we alter dysynapsis later in life? Sometimes grant reviewers will say, well, if you're born with, or, if this is established early in life, who cares? We can't change it, so why pursue it further? I'm not totally sure of that. I appreciate the pessimism, but because it forces you to really think about impact. But I think there may be some active processes that we could act upon above and beyond sort of, prevention, avoiding smoking, avoiding air pollutants, and so on. But more biologically, in this study, this is pilot data. I shouldn't say it's unpublished, but we took airway brushings from non-smokers who had this dysynapsis trait assessed by CT, and we measured bulk gene expression from the airway epithelium. And it turned out that these markers, so these are sort of classical markers of airway basal progenitor cells, sort of stem cells of the airway tree, that are responsible for, maintenance, homeostasis, repair. And what we found were, so these are 20 never smokers, so take it with a grain of salt, but there was a correlation between the level of basal cell progenitor markers and airway to lung ratio, suggesting that people who have these more hypoplastic airway trees, who develop more hypoplastic airway trees, may have less propensity or capacity to maintain themselves in adulthood. So that might be an active target in the era of stem cells and regeneration. Aerosolized basal progenitor cells to boost your airway tree. But I think most immediate is more of an understanding. Most immediate in terms of clinical relevance is an understanding for both the clinicians and perhaps even our patients to understand why their disease course is the way it is, or why it might be. So heterogeneity of disease phenotype, heterogeneity of treatment response, and I can't not mention mucus plugs, but susceptibility to mucus plugs with respect to these small airways or big airways. So when I'm referring to heterogeneity of disease phenotype, I'm sure you all have patients who have, I don't know, asthma, for example, who have markers of Th2 inflammation that are in the same range, but their phenotype, their degree of, their exacerbation frequency, their exacerbation severity may differ quite a lot. And when I think back to those CT scans of airway trees, the person with the tiny twigs, it seems like almost anything could tip that person over in terms of showing up to an emergency department or to being admitted to hospital, whether it's RSV or some seasonal allergy, wildfire smoke. Whereas the person with the really big airway trees, they might brush it off, not really feel much, even for the same level of inflammation. Similarly, treatment responses, I highlighted before that there's some variability there. And some colleagues who are really into quantifying mucus plugs there's experts here for sure in this that I'll be talking with later. There's a question about whether this native airway tree structure influences your susceptibility to mucus plug formation, persistence, type, which I think is interesting. I'm not a mucus expert, but I could imagine that the ability to clear out a mucus plug may be related to the caliber. I don't know if the whole mucociliary apparatus scales proportionate to the airway tree, or if maybe it doesn't, in which case you'd have either too much or too little mucus. Anyways, thoughts for future research. So do we need to do CT scans to quantify dysynapsis? I sure hope not, because it's not easy. There is some mention of dysynapsis in the recent ERS ATS technical standard on interpretive strategies for routine lung function tests. I would say that it came to me a bit out of nowhere. So this is the table where it's describing what obstructive impairment is, restrictive impairment, and they have this line about dysynapsis, and they describe typically an FEV1 is normal. The FVC can be normal or increased, and the ratio is low. There's not a lot of data behind this definition. This reference actually is an editorial. But I guess if I didn't know that it was on a Royal College, but so this might be something to retain. I'm not an examiner, but I mean, I would prefer that the proposed definitions be based on rigorous data, observational, either even risk-based. So there is a notion of dysynapsis idiotypes. I don't know if this will get back to your question, but there was a recent review where they highlighted that dysynapsis is a mismatch between airways and lungs. And in fact, conceptually, at least, so basically it's a ratio, and you could have a numerator problem or a denominator problem, or both. And so they kind of schematically said, here's, a depiction of someone with dysynapsis who has small airways. Here's a normal proportioned lung, and here's someone who has big lungs. And technically, these would both, align with that original definition of airway to lung mismatch proposed by Green back in the 70s. So we thought we could probe this a little bit thanks to CT scans. So here, this was using CanCold data, where they've all done cardiopulmonary exercise testing by the experts in the field, with IC maneuvers and the works to really map out mechanical constraints and so on. And so what we did was we computed the airway tree size and we computed the lung size, and we wanted to see whether the two pathways to having a low airway to lung ratio had equivalent physiology in terms of obstructive responses. So here, these were never smokers, no diagnosis of lung disease, about 161 participants. And what we saw was that this smaller airway idiotype was associated with evidence of higher dyspnea, higher signs of critical inspiratory constraints, not much difference in their peak VO2. These are pretty healthy individuals. But so there was signs of obstructive physiologic responses at exercise. Whoops. Keyword. When we looked at the bigger lung idiotype, we did not see evidence of obstructive physiologic responses. And in fact, the VO2s of these individuals were way higher, which is a favorable thing. These peak VO2s were way higher, which is presumably a thing. This is independent of age, sex, and height. So it would see, this is like an ATS abstract by Sophie Collins, a great postdoc. But this would suggest that the two pathways to an airway to lung mismatch, smaller airways or bigger lungs, are quite different prognostically. And the last thing I'd highlight is when we look at that ATS-ERS definition, spirometric definition, it actually is associated with the bigger lung idiotype and not a smaller airway idiotype. So this idiotype is actually a favor. I would love to have big lungs because I could have a higher VO2. I would not want to have the small airway idiotype because they're more predisposed to obstructive physiology. So while I think you should know this definition if it was on the Royal College, I think it might change in the future because it just doesn't seem to be picking up on the thing we'd be most concerned about clinically. So last knowledge gap slide, and then I'll wrap up. So I highlighted that people with SS dysynapsis have higher incidence of COPD, higher mortality from COPD, but also cardiovascular disease, lung cancer. I mean, that's really weird. What are the potential mechanisms? Residual confounding, first and foremost. But maybe it's just a smaller pipe problem. They have smaller pipes, less physiology. Maybe they're more inactive, more sedentary. can't really tie in the lung cancer, but that's one possibility. Altered particle deposition is another possibility. Impaired ability to maintain the lung, sure. Maybe it's a generalized problem, not just their airway trees are underdeveloped. Maybe their vascular system is underdeveloped. Their biliary tree, their salivary glands, I don't know. And the last one is maybe their immune function or immune system is also mismatched or dysynaptic. And that's what I'll talk about in the subsequent talk. So to summarize, the hypothesis of dysynapsis was introduced 50 years ago to explain inter-individual differences in maximum expiratory flow among young, healthy adults. Our results suggest that there are substantial between individual differences in the airway size independent of lung size that may reflect disproportionate growth. And I thought they were spot on here, but they sort of concluded their paper with, who knows, maybe this has relevance to airway diseases, may predispose to certain pathologies, particularly those associated with environmental hazards. I mean, I'd say the past 5 decades have largely validated what they hypothesized and expanded upon it, I hope. So what are the clinical takeaways? So I often, we have clinical rounds and research rounds back at McGill, and the clinicians there are a tough audience. They're very pragmatic, and it's great. So I think first and foremost, one thing that I appreciate now is that there's variation in native lung structure that is common, and it likely contributes to the clinical heterogeneity that we encounter in our patients with lung disease, both in terms of susceptibility, disease progression, treatment response. And while that's very observational, but like, what do you do with that? I think it's helpful to me, and sometimes it's helpful when I explain this to patients. Not always. I think that simple methods to detect and strategies to act upon dysynapsis are clearly lacking. CT is pretty rampant. It's not hard to get a CT scan, but quantifying it is not trivial. I have no point in the talk if I actually describe or define a threshold of, okay, this value of airway to lung ratio means you have dysynapsis and this means you don't. Because in everything we've looked at, it's really a continuum. Smaller is worse, bigger is better, and there's no sort of threshold that we see. So I suppose the median is the best place to split. I think that from a slightly more research perspective, understanding the origins of dysynapsis, what are those periods of susceptibility? Is it in utero, at infancy, childhood, adolescence? And what are the mechanisms of later life morbidity and mortality? We can better understand these things. It may open up some new avenues for disease prevention and treatment. So I'll stop there, and thank you again for your attention.
That was fantastic, and I appreciate that you've left time for questions, because I think that there will be quite a few, and we already have a couple of hands up. Josh, you were faster than Dr. Nair.
So I'm really curious about the different deposition of potentially what we hope are beneficial, our medications in people with dysynapsis. But I wonder, like, have you looked into it all, like higher incidence of side effects? Like, too much ICS deposition might not be good. Too much beta agonist might predispose people to have side effects from our inhalers and things. Is that something that has been looked into at all, or could be?
Not to my knowledge. I have not looked at it, and it's something I hadn't considered at all. Would be so. One of the challenges with this CT measure, I would love to get away from the CT measure, because it's harder to do, more costly. Not as many cohorts have that kind of information. If there was something that was readily available, we could probe those hypotheses. Like, Health Canada, we report adverse events to Health Canada, but we don't know what their airway scaling is. How do even something like UK Biobank, they haven't done CT scans of the lung. So where you might have the power to resolve that, but it's an interesting case to make. Thanks.
Thanks, Dr.
Thank you.
Two very clinical questions. We've got, as probably Sarah has got an active research program looking at this, and she'll be talking to you about this, about deposition. She's got a paper with a postdoc, a PhD student, specifically showing that this is relevance to inhaled corticosteroid deposition, but it's also modified by what is in the airway, the inflammatory component. So the aromatase plus the inflammatory component determines depositions in thorax. Two questions is you never mentioned the word airway hyperresponsiveness in your talk.
Yeah.
So the first question is it possible that in patients with normal FEV1, just as FEV1 and the FEV1 BC ratio determines hyperresponsiveness, would this concept of dysynapsis, because we have a couple of patients that we had looked at the airways with imaging. They've got small airways, the ratio of everything that you need, and they're exquisitely twitchy. And those are the patients after controlling inflammation that Dr. Cox would perform bronchial thermoplasty, but we refrained from doing that in these patients with small airways. So first question is, have you looked at whether this is a determinant of hyperresponsiveness?
I have not looked at. I think it probably is, partly for pragmatic reasons. So the notion of, so I have not looked at it is my short answer. What I've been fascinated with recently in trying to study how lung function changes over time is that with aging, the rate of lung function decline is highly dependent on your baseline value in perhaps an unexpected way, contrary to the Fletcher-Tito understanding. People who lose the most lung function people with the greatest lung function at baseline lose at the fastest rate. People with lower lung function lose at a slower rate. People will often say, that's because people with more lung function have more to lose. It's a bit of a hand-waving phrase because it's mixing the description of the phenomenon with the causal explanation for the phenomenon, when really that's describing the phenomenon. When I look at current smoking, the effect on rate of decline, it does not have that property. It seems to have a pretty consistent, people who are current smokers experience accelerated rate of decline, and it seems to be independent of what their starting value is. When I look at pharmacotherapies, it's actually the opposite. People with the greatest when I talk about pharmacotherapy, I'm talking about short-acting response. That's easily available data. It's the opposite. People with the highest values seem to exhibit the least response. People with lower values have a bigger response, independent of asthma to the extent that I can rule out asthma, which is quite poorly in these cohorts. The reason why I'm saying all of this is that so I have no idea what methacholine does in relation to the native airway structure, if it's independent of the bronchomotor tone at the moment. But I suspect that a bronchoprovocation that delivers the same amount of bronchoconstriction in someone with small airways versus someone with big airways, I don't think the effect on flow will be equal. I think it will be much worse. So it's a nonlinear relationship. And so that's where I think this small airways broncho responsiveness is interesting, but not understood to me.
I mean, in the 80s, there's been literature that this might also have an effect on deposition of the methylcobalamin.
Sure. Yeah.
They use histamine in those days, not methylcobalamin.
Yeah.
So it might be a reflection of the geometry, but also deposition.
Yeah.
The second quick question is about also, does dysynapsis in any way relate to branching morphogenesis? Have you had a chance to look at branching morphogenesis or in those epithelial markers? Do you have a chance to look at any of those markers like FGF or anything which might be fundamental and explain why you have coronary artery disease, whether they may have problems in pulmonary hypertension, other glandular structures that branch?
Yeah, that's a really great point. In fact, this, get back there.
You might need to just click on the screen first and then you can get through.
So that's a really great point. Like a personal fascination of mine is this all started with us looking at the branch pattern. So not the caliber, but the actual topology, using a very tedious study of just looking at the segmental branch variation just in the lower lobes. Took years to do. This was visually annotating who is missing their RB6, who is missing their RB7, who has an accessory RB star. Very painful, but it turns out there's a lot of very macroscopic variation in branch structure. This was replicated in 2 different cohorts of thousands of individuals. Much more common than I appreciated from my clinical training, which was at McGill, not here. I'm sure I would have known it if I trained here. But so very common. Who cares? Because it was associated with COPD. But most interesting to me was that we did a GWAS of these people who had altered branch structures, and we were underpowered. But the one hit was in FGF10, fibroblast growth factor 10, which is critical to branching morphogenesis. And what's even more fascinating is that the underlying program that regulates this, that's on the screen, this interplay between the endoderm and the mesoderm, it's all these feedback loops that involve fibroblast growth factor 10, hedgehog interacting protein, sonic hedgehog. It's pretty well mapped out, not completely, but those branching patterns are, if you go to the renal world and you talk to developmental biologists of the kidney and the ureteric tree, it's the exact same players. The salivary glands, the exact same players. In fact, there's a very rare genetic syndrome. It's some acronym that I can't remember now. Aplasia of the salivary and lacrimal glands, but super rare syndrome in FGF10. They lack salivary glands. They're constantly tearing because they don't have tear ducts. And sure enough, someone went and tested them for COPD, and they had much higher prevalence of COPD spirometrically in their 20s. So I think you're onto something. The vasculature, the regulation of that branching seems to differ a bit from those other epithelial line structures, but nevertheless, I think it has to be probed. Because
we could intervene here too.
Dr. Dwong.
There's an institute for that, the circulatory and respiratory.
In all of your adult cohorts, do you have any history of prematurity or early life injuries?
No. The cohorts are mean age now is in their 70s. They may be enrolled in their early 60s, late 50s. So there's a few, I guess, period cohort effects there where there's not, recall bias. Neonatal intensive care wasn't what it used to be. In the next talk, I will, using a different measure, relate it to prematurity in I think a very rigorous way, but not in these cohorts.
I do have a second question. It's pretty straightforward in terms of clinical labels and definition. How is this different from pre-COPD? And how is it the same?
Mm-hmm. There's a paper coming out on pre-COPD soon, which unrelated to this, but so pre-COPD, well, that's it depends, I guess, how you define pre-COPD. In this discussion that I was recently part of, similar to the cardiovascular world, where they've made a lot of progress by identifying people who are at higher risk of cardiovascular events. I guess in some ways that's pre-cardiovascular disease or heart disease. I think that's the way that people in the pre-COPD space are thinking about it, is not everyone who smokes or not everyone who doesn't have COPD is pre-COPD. We need to sort of identify what are the aspects that really put them at risk or where they're just on the cusp. And I think one of the strongest predictors is if your FEV1 FVC is just above that threshold, you're 11 times higher risk ratio. But so I think if the spirometry in these 4 individuals specific, like this person's ratio, never smoked, never had asthma. This person's ratio is 0.6. So they would already meet the spirometric criteria for COPD. This person was 0.71, I think. So I suppose, so this end is either pre or already there, depending on how you define COPD. This person at the other extreme has a ratio of 0.91, which I always thought, oh, that's odd, but they're endowed with like really big airways, and they're further from that threshold. So they're the opposite of pre-COPD. They're like distant from COPD.
Thanks, Ben. That was fantastic. As Karen alluded to, we've been starting to look at CT-defined dysanapsis in our asthma patients. And to comment on the hyper-responsiveness, we've just compiled the data looking at the drop in FEV1 through saline inhalation. And we did what we've observed in our, it's like preliminary data, just a retrospective analysis, that those people who did bronchoconstrict more with saline they were above the median of our dysanapsis. So they had smaller airways. So that's kind of interesting. That adds some data to the hyper-responsiveness angle. But what I'm interested in is your thoughts on, and you touched on this a bit, intrinsic versus acquired dysanapsis. Because I think in our asthma patients, probably a lot of what we're seeing is driven by the disease pathology. So the airways are just smaller, and we can modify that with treatment. Do you have any, or have you thought about the importance of distinguishing those when it comes to, using this metric in clinical practice?
I've thought a lot about it. I don't have a super clear answer. And if you speak to 10 different people on the subject, I find people have different understandings or conceptualizations of it. I think of dysanapsis as anything like by the end of growth of the lung, anything that may have resulted in a disproportionate growth, whether it was genetic, super prenatal, disease processes like asthma in childhood, if that somehow affected how the things grew and you ended up with a mismatch, I think that's fair game. Should we have separate labels? For sure. I think that would make a lot of sense. If someone is having super active asthma in adulthood, it's harder to tease out if that mismatch is from active, asthma, bronchoconstriction. I mean, we can try to, but versus something that was truly developmental in origin. That's where I guess imaging. So we're trying to do some MRIs in adolescents to get into the younger space where growth is happening would really help to map that out. CTs, people are averse to that. So MRI is a space where we've made some progress.
And then I guess follow-up question, do you have an established kind of upper limit normal for the metric?
We can, we're trying to, it's like a paper that's kicking around that has to get done where we're just looking what best discriminates respiratory hospitalization or death versus not as some sort of anchor on, okay, well, that's bad. So, and it really seems to be in the median. And I think that's just what happens if something is really kind of monotonically, linearly related, it hones in on the median, which means half of people have.
Great, thank you.
I actually have a related question.
Okay.
So has there been any interest in the concept of a post-bronchodilator assessment of dysanapsis since methacholine make the small airways smaller on CT and bronchodilators make the small airways bigger on CT, and the people with smaller airways have a bigger bronchodilator response? We define COPD based on a post-bronchodilator FEV1 that shows obstruction. Should we be looking at post-bronchodilator CT scans?
Oh, that's interesting. Okay. So that's a great idea. Hadn't thought about it. Even in that spirometric definition, at a minimum, they should recommend that it be post-bronchodilator to rule out, possible asthma, or let's say related, or bronchomotor tone related deficits. So that was a great suggestion that I've never thought of, the spirometry definition. And for the CT, I mean, it's been shown that can resolve pre-post bronchodilator CTs. You can see changes in the caliber that are measurable. So that would be another good point. This was all done pre-bronchodilator, so maybe we're missing stuff. That's a good point. Okay.
I'm actually going to take advantage of my spot to ask one more question.
Mm-hmm.
So, and this is just my ignorance on the subject because I have several people here more expert than I am. So you're measuring the lumen diameter. So there's outer diameter of the airway. There's the airway wall.
Yeah.
There's mucus, and then there's airspace.
Yeah.
How does your system differentiate, and what is the lumen that you're actually measuring?
It's great question. It's lumen diameter. We've looked at wall and things like this. We haven't partitioned wall and mucus. I don't even know if that's possible. You guys could probably do it, but I can't. So this is just lumen. These are people who.
So just the airspace.
Yep. And these we don't expect them to have a lot of mucus plugging, but when this imaging was done, mucus plugs were not the thing they are now, thanks to you guys. So I don't think there was, and we also focused on very central airways. I won't even say that because there's many papers showing that there's mucus plugs in the central airways, but so that's an uncertainty.